this is just a brief outline of the talk for today. We'll talk a little bit about what the prostate is, what it does, the diseases of the prostate, and what strategies we use for diagnosing prostate cancer and what the management options are. So that's a little diagram of the prostate. To the left, you have the bladder on top, the prostate in between, and then the urethra just below the prostate. A portion of the urethra actually traverses the prostate. What does it do? It contributes nutrients to the semen, and it also produces an enzyme called PSA, prostate-specific antigen, that liquefies it, makes semen a little bit more fluid and allow sperm to be able to travel. That last bulleted point there says it's not a vital organ, and it would because it does serve some function, but it's not a vital organ in the sense that if you were to get rid of it, it's not life-threatening to get rid of the prostate. So the prostate can be affected by diseases that are benign as well as diseases that are cancerous or aggressive, as highlighted in the previous slide. So benign diseases, just benign enlargements of the prostate. As we grow older, the prostate gets bigger, and a lot of times the symptoms that men experience when they grow older related to the prostate actually due to a benign process or inflammation of the prostate, whereas it could also be due to cancer, especially if the cancer is very advanced. What you're seeing here is a slide of the incidence of prostate cancer among Black people in the United States. Much like any health condition, prostate cancer most commonly affects Black men more, and is the second leading cause of death among Black men. And this micrograph really shows or highlights the differences or the disparity that exists when it comes to prostate cancer. It's estimated that 1 in 6 Black men will be diagnosed with prostate cancer compared to 1 in 8 white men. And then, 1 in 8 white men, and then 1 in 26 Black men will die from prostate cancer compared to 1 in 44 white men. And the reasons for this disparities or differences have already been highlighted by previous speakers, particularly Dr. Baines. It ranges from structural to social to health to survivorship, what treatment options your doctor will offer you, and how they'll monitor you while you're on treatment. There's so many reasons. It's a very, very complex situation that I think, as highlighted previously, each one of us can play a role. We can really change that we want to see, including our patients being advocates for yourself. The way that we screen for prostate cancer is using the same enzyme that the prostate itself produces, PSA. It is actually the most widely used biomarker in the world. The challenge with PSA, though, is that it can go up when you don't have cancer. It can actually be normal or low when you do have cancer. So that's one of the limitations of PSA. That impacts how sensitive or how specific the test is. So it's important that when you get a test, PSA blood test, that is interpreted correctly. I think Jason alluded to this earlier. You could have a PSA that could be considered normal, and then you have cancer. In general, people refer to PSA of less than 4 to be normal, but a PSA of 3 will not be normal for a 45-year-old man. So it's important that you have a conversation with your doctor to know what the age-appropriate cutoff is. And there's some other derivatives of PSA that we use, like how fast the PSA is changing, is it doubling, and then there are risk calculators that we can plug PSA in, as Mr. Anderson alluded to earlier, that can inform for the risk of having prostate cancer. But why is PSA-based screening important? Since the introduction of PSA screening in the 90s, there has been significant reduction in the incidence of metastatic prostate cancer. That is, prostate cancer that has spread. You can see the striking difference between the impact of PSA screening and the impact of mammography screening for breast cancer. Same is true when you look at the incidence of death from prostate cancer. It's been reduced by 20% since the introduction of PSA screening. Of course, PSA screening is not the only reason why we've seen this significant reduction. There are other things like innovation, like robotic surgery, prostate cancer, systemic treatment for prostate cancer. But PSA screening is really has a big impact in the reduction in incidence of metastatic prostate cancer or death in prostate cancer. Prostate cancer screening does come with some harm. The anxiety was mentioned previously, and some of the side effects of the diagnostic procedures like biopsies, the side effects of treatments associated with the different options that we have available. So patients and physicians have to engage in a shared decision-making process to talk about the benefits and the harm. And the overall goal is to have a situation where the benefit of screening far outweigh any harm associated with screening. Because PSA has limitations, there are other biomarkers out there that can be used to supplement the performance of PSA that providers should be having a conversation with their patients when they see them for consultation. There are biomarkers in blood, there are biomarkers in urine that can be used, and then there are tissue-based biomarkers that can be used to supplement the performance of PSA as listed here. And these biomarkers their performance is very variable, but particularly I want to highlight the fact that they could be used to avoid unnecessary biopsies. They could be used to improve the detection of aggressive prostate cancer that need to be treated. But it's also important to know that these biomarkers do have limitations. They're not very well studied in underrepresented minorities. For example, some biomarkers include molecules that have a very low prevalence in Black men. So we would not expect those biomarkers to do well. So when I see a patient and I'm thinking about, ordering a biomarker test, I'm asking myself, why am I getting a test? What information is it going to provide for me or for my patient that will help them to make decisions that they need to make? And also it's important to have a plan developed with the patient of what to do when the biomarker test comes back. Because what this test usually do is provide a risk or probability of having cancer. For example, a test result might come back and say the patient has a 10% risk of having cancer, and say 10% risk, I'm good, I'm not going to do anything. Whereas a test result of 5% may make a patient anxious and want to do something. So having a plan developed with the patient before ordering the test, I think, is important. And there's no need to order too many tests. I'm going to skip this just in the interest of time. This is just highlighting when I use biomarkers. And then move on to, okay, now you've got a PSA that is suspicious, or you've got a biomarker that is suspicious. What's the next step? The next step is to do a biopsy. Really, that's the gold standard of making a diagnosis of prostate cancer. We have different ways of doing that, and the old days used to be finger guided, but now we've got technology to assist with doing biopsies using ultrasound or MRI. There are two different approaches, transrectal or transperineal, to avoid putting needle through stool. And MRI has really changed the way that we diagnose prostate cancer, because MRI can actually help you identify a target, a suspicious area in the prostate that you can direct your needle when performing the biopsy to improve your ability of detecting more cancer, increase the specificity of the biopsy process so you can reduce the number of biopsies that you're actually doing. This is a summary of the AUA guidelines that came out last year on when to use MRI in the diagnostic pathway for prostate cancer detection. And this is something that we actually struggle with a little bit as to whether to recommend MRI for everybody when you're undergoing your first biopsy. Personally, I order MRI before any biopsy, whether it's your first biopsy or your repeat biopsy. But we understand that there's some limitations in some centers, especially in the community, where the performance may not be as good. But certainly, any patient who is undergoing a repeat biopsy, meaning they had a negative biopsy and you're still worried that they may have a prostate cancer, you should certainly get an MRI before performing a repeat biopsy. Now, the biopsies come back and it shows cancer. Prostate cancer is assessed on a Gleason scoring system shown on the right that goes from 6 to 10. The scoring system is a little bit confusing. So the newest system is shown in the middle, the grade group that goes from 1 to 5. 1 is the least aggressive, 5 is the most aggressive. And then we also have a 3-tier system shown on the left, low or very low, then intermediate risk, and then high or very high risk. And these risk categories are used to determine what to do. In general, patients with prostate cancer or low or very low risk prostate cancer do not need treatment. You can keep an eye on the cancer. Some patients in the middle bucket are favorable intermediate risk prostate cancer, group 2, will be eligible for keeping an eye on the cancer. Certainly patients with group 3 or unfavorable intermediate risk or high or very high risk prostate cancer should be offered treatment if appropriate. And this is a summary of the treatment options available, but I highlighted in red the 3 most common options that we offer patients. One is active surveillance, radiation plus or minus hormone therapy to shut off testosterone, or surgery, prostatectomy, which majority of prostatectomy is done today. Probably more than 99% are done robotically. These treatment options do have side effects, such as single erectile dysfunction, urinary incontinence, and the logistics of treatments and the side effects associated with these treatment options often inform what option patients decide to go with. What I usually tell my patients is the fact that radiation and surgery are equally effective when it comes to curing the cancer. The difference really is the logistics and the side effects. And I always insist that my patients go for consultation with a radiation oncologist to get an unbiased presentation of that treatment option. It's something that I always recommend to my patients. And in Mr. Anderson's works, I think that also counts in some way as a second opinion. So I'll stop there and maybe conclude by saying that Black men are disproportionately impacted by prostate cancer, and that screening saves lives. Be your own advocate and talk to your doctor and engage in shared decision making. Thank you.